This video will cover percutaneous radiologic gastrostomy placement. Thank you to Dr. Glenn Hoots for his input and for providing images. The objectives for this presentation are listed here. Percutaneous radiologic gastrostomy placement is a minimally invasive procedure with success rates similar to percutaneous and surgical tube placement with a lower overall morbidity and mortality. That being said, it is limited by access to select facilities and patient anatomy. If there is not a sufficient window of access, for example, due to an overlying colon, then the tube cannot safely be placed. The ideal puncture site is the distal body of the stomach, equidistant from the lesser and greater curvature of the stomach. This minimizes the risk of damaging the gastric arteries or the gastroepiploic arteries. Care must also be taken to avoid puncturing the left lobe of the liver and the transverse colon, which can lie between the stomach and the anterior abdominal wall. PRG is most commonly indicated for dysphagia or poor PO intake secondary to CVA, neurodegenerative disorders, hypoxic brain injury, and TBI. Other reasons would be due to obstruction associated with oropharyngeal or esophageal cancers, burns to the upper GI tract, cystic fibrosis, and other diseases associated with malabsorption or poor GI motility. Absolute contraindications would include unsatisfactory percutaneous access and uncorrectable coagulopathies. Relative contraindications include portal hypertension and gastric varices, immunosuppression, interposition of organs, previous abdominal surgeries, ascites, and severe GERD. For this procedure, you will need 1 mg of glucagon, lidocaine 1% with epinephrine, a 22-gauge hypodermic needle, 2 to 3 T-fasteners, an 18-gauge single-wall needle, a .038-inch stiff guide wire, fascial dilators to 4 French greater than the gastrostomy tube, and an 18 to 20 French balloon tip gastrostomy tube. It is important to have larger fascial dilators because most sets have a deflated balloon that is not flush with outside of the tube, therefore requiring overdilation of the tract. As seen here, patients usually come to the IR suite with an NG tube already in place. Correct placement is confirmed by noting that the tube deviates to the patient's left as it enters the stomach and ends distal to the carina. It should also cross the diaphragm in the midline. Prior to the procedure, an ultrasound or CAT scan can be done to ensure no viscera, like the transverse colon or left hepatic lobe, is overlying the stomach. Alternatively, contrast can be given the night prior to the procedure to ensure that the transverse colon is well visualized and thus easier to avoid. Once in the IR suite, the stomach is insufflated with air to provide tension during the procedure, to provide a larger target, and to help bring the stomach in apposition with the anterior abdominal wall. The insufflated stomach is indicated by the red circle. Depending on the operator's preference, glucagon can be administered prior to the procedure to minimize gastric peristalsis and cause contraction of the pyloric sphincter. By minimizing peristalsis and contracting the pyloric sphincter, the amount of air escaping the stomach is decreased. As can be seen in this picture, insufflation of the stomach also helps to move the transverse colon inferiorly to reduce the risk of accidentally entering the colon. The Kelly clamp can be used to visualize placement and provide exact locations to place the T-fasteners. Puncture sites should be chosen that are roughly equidistant from the lesser and greater curvatures to minimize the risk of hitting underlying arteries. Prior to placement of the gastrostomy tube itself, 2 to 4 T-tacks are placed around the anticipated gastrostomy site to hold the stomach against the anterior abdominal wall in a process called Pexy. This helps prevent the stomach moving away due to loss of air when it is punctured. These fasteners are also used to secure the tube in place after placement. During entry to the stomach, there is tenting of the gastric wall. Puncture should be a swift, deliberate motion so as not to push the stomach away from the anterior abdominal wall. Once the needle has entered the stomach, air is aspirated and a small amount of contrast is injected to confirm correct placement of the T-fastener. A key marker of correct placement is visualization of the rugal folds when the contrast is injected. The remaining T-fasteners are placed following the same steps as outlined previously. A single wall needle is then placed at the site where the gastrostomy will be performed. Through this, a stiff guide wire can be introduced. After placement of the guide wire, serial dilation of the tract is performed until it is large enough to accommodate the gastrostomy tube. A stiff guide wire and careful manipulation will prevent accidentally pushing the muscular gastric wall away from the abdominal wall. A peel-away sheath is then introduced, followed by the gastrostomy tube. Once in place, the peel-away sheath is removed. Along with the fasteners holding the tube in place, there are a couple of methods that can help ensure the tube stays in place. Some, as seen here, have a balloon on the end that can be inflated to prevent the tube from backing out of the stomach. Others, such as pigtail or cope loop catheters, depend on the shape of the tubes to hold the tube in place. In these tubes, an internal tether causes coiling of the catheter tip to aid in securement. All catheters may also be sutured in place if necessary. When intragastric placement is confirmed with contrast injection, the guide wire is removed from the tube. Final placement is confirmed with contrast injection and the procedure is finished. Major complications are significantly lower for PRG when compared with other G-tube placement techniques, occurring in only about 5.9% of cases. Of these, dislodgement is one of the most common reasons for repeat procedures, accounting for 55% of repeats in one study. Other major complications include infection, bleeding, obstruction, and bowel necrosis. Minor complications include leakage and occlusion. With perfect care, tubes can last for years. However, this is difficult as tubes can become dislodged, clogged, or start leaking. Generally, it is best for the person who most frequently accesses the tube to know what to look for and call the physician if there are any concerns. There are many issues that can be fixed relatively simply, avoiding the need to remove or replace the tube. If the tube needs to be removed, it is important to know how the tube is secured internally. This dictates how the tube is removed. Some can simply be pulled once there are no fasteners, some require the balloon to be deflated first, and still others will require endoscopic assistance if they need to be removed. Thank you for your time.